So hi everybody, my name's Sian Dobbs. I'm a head and neck surgical registrar based at Manchester Royal Infirmary, and I'm also a PhD candidate at the University of Manchester. We also have Mr. Manny, who is with us today, who's also one of our consultant head and neck surgeons at Manchester. And today we'd really like to share and talk about our work that we're doing, supported by Salivary Gland Cancer UK in the surgical work stream. So as we heard this morning, the charity established several key aims and focus areas, and for the surgical question it was clearly quite an emotionally evocative question in that there's multiple areas that we wanted to talk about and what we wanted to improve for patients. But really, if you combine all of these together, it's about how can we make better decisions about salivary gland cancer for our patients, particularly in the context of surgery. In terms of why this matters, so surgery is the main treatment for salivary gland cancers. It depends on the site, the size and the extent of the tumour, and what that surgery may look like will be different for different patients, but it is the primary way that we treat salivary gland cancers. However, as we've heard today, it can have significant lifelong changes for patients. We want to know and understand how are those decisions about surgery being made, and what do our patients feel about them, and really importantly, what can we be doing as clinicians to help improve this? So some of the questions we are asking is, how are we deciding when an operation is possible or when it isn't possible? We've heard, and from our own anecdotal experiences, unfortunately sometimes patients have to seek second, third, fourth, even fifth opinions, and which can be varied even amongst the UK, never mind globally, about when patients are undergoing surgery and what type and extent of surgery that is. What are acceptable risks, and should those acceptable risks of surgery be defined by the surgeons or by the patients or by both? You know, we know that the surgery that we offer to patients has significant functional implications on such far-reaching aspects of patients' life, from speech, swallow, facial function, and really we need to move beyond. It's not just about survival, it's about living well after surgery and what we can do at an early stage as surgeons to facilitate that. So how can we have patients more involved in that decision-making process? It's really important to have individualised surgical decision-making. One surgery for one patient may be the right decision. For another patient, it may be something totally different, which is more appropriate for their care and more individualised to them. We are moving away, well, we have moved away, hopefully, from this sort of paternalistic nature of surgery where we say, this is the operation that you need. I don't believe that is good enough, and I don't believe that is acceptable for our salivary gland patient population, and I believe that those who are making the decisions about surgery should involve patients at that early process. So how can we support patients to be involved? And likewise, those decisions are really difficult because we don't have all the information. So we are trying to make really difficult decisions based on the information that we have. So how can we, as a collaborative with Salivary Gland Cancer UK, discover and find that information to help make those decisions easier for us? And really, this is sort of our goal of our workstream. We want to contribute to making our surgical decision-making shared with patients. We want it clear and transparent. We want it based on the best possible evidence, and we want patients at the absolute heart of that decision. So in terms of how we're doing this, do you want to talk a little bit about the ones, or do you want me to? We have with the different work streams, yeah. So when we meet as part of the collaborative, we have identified various areas of work streams where we are starting to make progress in this area. So I'll talk through each one very briefly. It is very much more of an overview. So when we talk about evidence base, is when we're sitting in the MDT and discussing and deciding what we think would be the best treatment for patients. We look at the trials that are available. We know that salivary gland cancers are rare, so therefore, relatively, in the grand scheme of things, the trials that are available are limited. And actually, when you look at what outcomes are being reported amongst those trials, we want to be able to compare and use that information as well as possible. Those trials report different outcomes. We have no standardised way of what outcomes are being included for us as clinicians to then relay to patients. And furthermore, we've also found through our work that the trials include very, very limited patient-reported outcome measures. It's very much more survival statistics. And as we've heard today, that is just not good enough for us to be basing our decisions on. So with Salivary Gland Cancer UK, we've started work as to what we want to establish as a core outcome set for salivary gland cancer trials. Whilst we are facing a rare disease, this will really allow us to then make the best use of what evidence is available out there to best inform our treatments. Another area of work which has been touched upon today, as we've spoken about, is what is happening currently. We're very fortunate to have a national healthcare system. However, we know from our own clinical practice that patients geographically have very different access to surgical care and what type of surgical care they receive. And one of the ways we want to try and capture that is collaboratively with the Salivary Gland Cancer UK survey of, well, what is happening? So what investigations, how are different specific areas of the surgical treatment being given, what rehab are patients receiving afterwards, how are they being cared for with the surgical team in surveillance. And we all know in the room that this is very, very different, and I feel like this is a good platform for us to advocate that on a national platform to show that patients are accessing different care. When we can have this, these are just examples of some of the national bodies that will be collaborating with this. It's trying to bring salivary gland cancer to the forefront of what we are talking about as head and neck cancer surgeons, because there is a lot of improvement that can be made. So we're contributing with that with Salivary Gland Cancer UK. A key area when we talk about offering surgery is the premise of having a surgical margin. So by that you have the tumour and essentially a cuff of normal tissue around it. And what we aim for is different in different centres or different tumour types. And a lot of the sort of numbers that we use for salivary gland cancer have been extrapolated from different tumour types entirely. And so sometimes we hear that there's decisions for patients to not undergo surgery are based on the principle of getting an adequate margin. That might not be applicable to salivary gland cancer. We just don't know. There's some initial evidence coming out that actually when we saw sort of microscopic disease, so by that when you, at the end of the operation, there's no cancer left to see, but on the microscope afterwards there are some small areas there still, there's evidence to suggest that that might not be something we should be using to preclude a patient from accessing surgical treatment. And so as part of this, we want to look back and have a large data set of patients who have been surgically treated to examine that impact. And it's going to be really difficult to change that surgical decision making without having that evidence and that data there available. So that's something we're working on within our Manchester cohort. We also have work happening in the laboratory. So we've spoken today, particularly in the early diagnostic aspects, about the challenges of diagnosis and also the challenges of surveillance. One of the areas that have come out from our research working group meetings is if we could have a non-invasive type of biopsy or marker that we could use to surveil patients and monitor patients. And so we've started to collect saliva samples from patients who have salivary gland cancer. And our plan and our aim is if we can fund this research would be to identify different signatures of proteins and markers within there that can then be used during surveillance or indeed to aid diagnosis in the first instance. Another area that we're looking at in the laboratory from a biomarker perspective is validating. So when a cancer is out and it goes to the lab, they have specific markers that are put on the slides. And there's evidence to say that within a specific type of salivary gland cancer, adenoid cystic carcinoma, we can't all, they behave differently. And so one measure of treatment won't necessarily fit everybody. And if we can stratify patients into these different types, we can tailor our treatment and our monitoring more appropriately for those patients. So for example, some patients may have more intense surveillance and may have more frequent scans, and the patients who actually may not need they don't have to come back to the hospital as much. We can personalise it much more. I think we need to move away from having a very standardised approach across to really tailoring it for our patients. So these are some of the examples of the work streams that we're looking at in the laboratory in the University of Manchester. And as we've heard today, the role of collaboration is really key, and Salivary Gland Cancer UK is a brilliant platform for us as surgeons to come, and we learn every time I come to an SG UK event. I learn from patients and other clinicians, and we can then take this and go off to our various surgical teams and share that more. But in a rare cancer setting, collaboration is absolutely key, and I think from the surgical work stream particularly, that is something that's going to give us a lot of strength and sort of information going forwards as to how we can really achieve those aims that we want to do. And I think that was really everything from a bit of a whistle-stop tour as what we're doing that we wanted to go through with everybody today, really. So I think I just also want to say thank you for Salivary Gland Cancer UK for the support of all the research and the opportunity to learn from everybody today. And yeah, I'm looking forward to working with everybody going forwards. Thank you very much.
Typically, margins up to now are based on experience from more common tumour types.
Yeah.
So for more common tumour types in the head and neck, we tend to look for 5mm margins. That's always been our standard, and it still is for a lot of other head and neck cancers. But we know that the biology of salivary gland cancers are different, and therefore, and the other thing we also know is that in certain areas, say for example the parotid gland, where you've got a really important nerve running through it, like the facial nerve, you can't achieve those margins without having to remove that nerve and then causing unnecessary additional morbidity. So we do tailor it more, and the current thought process for many of the salivary gland tumours is if we can remove the tumour what we call macroscopically, so everything we can see. So we're much more willing to accept closer margins. One of the discussions we often have in our MDT meeting afterwards is about whether to give radiotherapy afterwards, and that is often based on margin status, and because we end up with narrower margins with salivary gland tumours, that's why a higher proportion of patients go on to have radiotherapy as well.
Well, that was kind of a follow-on question, because that's the advice that I've seen anyway, that you should really mop up with radiotherapy.
Yeah.
I was wondering about, based on those margins, if you can go with less margin, because surely radiotherapy would then hit it anyway and deal with it, rather than saying you can't have surgery because we can't get a 5mm margin.
I mean, you could potentially extrapolate it even further to identify, are there a subset of tumours where actually they might not need radiotherapy afterwards, and perhaps we're over-treating some patients, and we could potentially spare them from the effects of radiotherapy, but we need, again, it's this sort of blanket rule almost that's applied across all the different types of salivary gland cancer, when we can see clinically that they clearly behave differently. And I think, I haven't really gone into massive detail about it from one of the biomarkers, if we can use that to say, actually, this patient has this particular tumour, which actually we really should be advocating for maybe more radical surgery or addition of perhaps intensifying their post-operative radiotherapy, and then identifying the patients where we can potentially pull back a bit. And I think it's having that objective information to help inform those decisions, and to try and influence that with based on scientific evidence.
Yeah, and actually we know clinically as doctors that some tumours do behave in a much more aggressive fashion than others, but like Sian says, it's identifying which those tumours are, and it's knowing what the markers are we can find, and that's where the science is going to move us forward. Something that we are doing collaboratively, which is amongst the doctors, is doing the survey. So looking nationally at practice, because there's such a huge variation in practice. Margins are one thing, deciding on which tumours are operable or not is something else. So by trying to gain data from throughout the UK surgical practice and looking at the variation, that can help us form tighter guidelines that mean that there's more standardisation throughout. So that's sort of more national collaborative work.